Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Cal Vista.
Hello, Glasgow. On behalf of Medscape, I'd like to officially welcome you to our Medscape Live news report. Today's breaking news, hereditary angioedema headlines. My name is Taryn Winterbrill. My friends call me TWB. I am a medical journalist. I will be your host, moderator, and roving reporter for today's presentation. More on the roving reporter part later. That's going to be a lot of fun. If you couldn't tell from my accent, I hail from the United States, New York City specifically. Fun fact about Glasgow that I learned on the plane, this is the birthplace of the raincoat. A scientist invented it here in 1823, a Scottish chemist. So good to know. You never know, you need a piece of trivia about a raincoat at a moment's notice. So keep that in your back pocket. And with that, I'm going to cue you up for another quick video right now that's going to kind of give us a roadmap into what today's conversation is going to be about, what we're going to be delving into. So since this is a news report, doctors, what do you say we roll it?
Welcome to Hereditary Angioedema Headlines. Individuals with hereditary angioedema experience unpredictable and frequently debilitating episodes of tissue swelling, which can pose life-threatening risks, particularly if they involve the upper airway. Consequently, hereditary angioedema significantly affects both the short and long-term aspects of patients' lives. Daily activities may be hindered, leading to decreased productivity and missed days at work or school. Many patients report experiencing depression and anxiety, and the fear of future attacks often restricts their ability to socialize or travel. Despite advances, patients still face debilitating attacks due to the treatment burden associated with on-demand therapies, which can delay their timely use. These delays can have significant impacts on patients, including more severe and prolonged attacks, increased hospitalization rates, and greater physical and psychological distress. Over the next hour, experts will share the latest insights into the treatment of hereditary angioedema, from importance of early intervention to examining the potential of emerging on-demand therapies. We'll dive deep into the challenges faced by both patients and healthcare providers. Stay with us as we explore this critical topic to enhance our understanding of hereditary angioedema so that we may improve the outcomes and quality of life of our patients.
All right, let's do it. It is time to meet our all-star panel finally. Dr. Jones, please introduce yourself.
Hi, I'm Dr. Doug Jones. I'm from the United States, specifically the state of Utah, and I'm excited to be here. I've been in practice for close to 20 years and been heavily involved in the hereditary angioedema space throughout that time.
Hello, everyone. My name is Autumn Burnett. I'm an assistant professor of allergy and immunology at Howard University in Washington, D.C. I have an academic practice that I participate in, and I also have invested the majority, if not all, of my career to treating patients with hereditary angioedema.
Hello, I'm Hilary Longhurst. I live and work in Auckland, New Zealand, looking after the hereditary angioedema and other patients with immunological disorders. And I've worked with hereditary angioedema patients for a very, very long time, since before we had all the amazing therapeutic opportunities we have now. So, and I'm delighted to be here.
Oh, we are delighted to have all three of you. With that, I think it is time to dive into our first segment. What do you say, Dr. Jones? Shall we do it?
Sounds great. So thank you for joining us again. We're going to take a really deep dive into what really gets behind the HAE attack and uncover the real burden of HAE. And what we want to do over the next few minutes is help you enter the minds of our patients. What conversations are going on in the minds of our patients? Because once we understand that, then we may be able to understand some of those deeper challenges that patients may face. Just as a slight introduction, HAE is a rare, I like to call it more uncommon, autosomal dominant disorder. It's associated with unpredictable, painful, and often debilitating attacks, and they can be potentially life-threatening. Now, think about that. If something's unpredictable in your life, how does that go? We all like, I think, predictability, but if something's unpredictable, that causes us some amount of uneasiness. What if something was potentially life-threatening? That also can cause a lot of uneasiness. Well, these patients, the nature of the attacks, they're unpredictable. They can be debilitating, disfiguring, potentially life-threatening. All of those things combined, in addition to many of these patients have gone years, if not decades, with a misdiagnosis, being told they have something else, whether it's food allergies or lupus or rheumatoid arthritis, and treated with steroids and all the things that don't work. So there's this mistrust that can also occur because of delayed diagnosis or misdiagnosis. Coupling that again with the unpredictable, potentially life-threatening situation that they're in, what would that lead to? If this was you, if you experienced this, imagine you going through years and years of misdiagnosis, or a delayed in diagnosis, being treated with wrong medications, and you're still suffering. Perhaps it might lead to depression, anxiety, restrictions from social activities, work, school. Imagine right now, in fact, if you had the disease. Put yourself in the situation of a patient. What if you had it and you're sitting here right now in this Medscape Live? You're wanting to hear this presentation, and all of a sudden, what if you started to notice you started to swell? What if you were swelling right now? What would you do? What thoughts would go through your head? What would be going through your mind? Are you going to leave? No, you're not going to leave. This is a mess. This is an amazing presentation that you're going to. You don't want to leave that. You want to stay here. But if you delay treatment, will it worsen? Will it become disfiguring? Will it become life-threatening? Do you run the risk of having to go to an emergency room in a foreign country? Do you run the risk of missing dinner plans with colleagues and friends later tonight? This is the dilemma that you potentially would be going through if you were swelling right now, especially if you had limited access to treatment options, potential side effects. This is the life of a person with hereditary angioedema every day in any situation. I just kind of wanted you to keep yourself in that type of situation because that's what they deal with. And there's a massive burden of disease on these patients.
HAE, hereditary angioedema, swellings impact my life, every aspect of my life and that of my husband. And it affects all day-to-day activities. The effects range from being debilitated in excruciating pain and suffering from exhaustion, being ill, being incapacitated for sometimes up to 5 days with the swelling attacks. tasks, everyday tasks, like if you think about, I want a cup of coffee, if I've got very swollen hands, it's really difficult to make a cup of coffee. To brush my teeth, to brush my hair, to have a shower, to put my feet when they're extremely swollen into shoes, can't do it. It affects all activities and tasks every day, and particularly if I have an HAE stomach swelling, which is absolutely excruciating and causes severe vomiting. Not being able to go into work, I'm retired now. When I did work, it really impacted my work. I had a lot of time off work. And when I was at work and had a HAE swelling, I would have to come home or ring a family member or my husband to come and collect me. So not only did it impact my life, it impacted their life and still does.
All right. Thank you, June. That was one of our patient videos discussing the burden of living with HAE. June is from the UK, and it's really just so important to get the lived experience from an actual patient. I'm going to toss the mic over now to Dr. Burnett.
Yes. So, let's transition. We've talked a little bit about the burden. Doug, you brought us on into that kind of space, the mentality, the fear. Now let's talk and transition a little bit more, go in depth, and talk about the importance of early intervention. So, what are you're having an attack? It's in that moment. Let's talk about what we're going to do. The importance just generally of treatment. We know there's different ways that we can treat HAE, right? We know that there's prophylactic preventive options. We also know that there's on-demand rescue options. Truly, for this type of disease, it is important to think and act early. The importance of early intervention with an on-demand medication is something that the guidelines really hone in on. And one of the reasons why the guidelines hone in on demand treatment is because of two main key reasons. One, the goal is to arrest the progression of the attack, reducing the severity, reducing the longevity, the duration of that attack, potentially preventing serious and potentially life threatening outcomes. Another key component of early intervention would be getting those patients that sense of control back. Doug, I think you mentioned earlier that they don't feel in control. It's unpredictable. And really getting a sense of control back, I think, is really key in terms of how we think about rescuing patients and treating those symptoms early, right?
Especially if they're in like a social situation, a
Correct.
work situation. It's like, well, what are they going to do in those types of situations if they have to, something's coming on and they're having to treat and they have those dilemmas in their minds.
The anxiety makes it worse too.
Yeah.
When you're in a situation where there's high stress, you could be driving, you could just, you could be doing something that is, uh, you know, the importance of arresting that attack, the importance of getting it early, could really be you could be on an airplane for 8 hours. I just flew over across the Atlantic Ocean. And so there's so many instances where the anxiety actually um, it can rise depending on the context of the situation, particularly on things like airplanes and traveling. And so anxiety is important to gain control of so that people feel like they can get control of the unpredictability and just improving someone's overall well-being of their disease, making the situation less unpredictable and more predictable, and that they can get a grip on things. So here we have a consensus, if you will, in terms of treating attacks, treating them in an acute and on demand type of way from the US HAEA and also from the WAO EACI guideline recommendations on how we should really think about treating patients early in an on demand way. The consensus across both of these guidelines is to treat all attacks irrespective of location or severity. And I think there's just a consensus and agreement that all attacks, mild, moderate, severe, doesn't matter where the location is. It could be an extremity, could be something more intense in the abdominal area or something even more life-threatening in the laryngeal area, but all attacks, irrespective of location and severity, should be thought about in terms of treating with on-demand medication. And also the consensus is to carry at least two, enough medication to treat 2 attacks. And so, that's also key. And the ability to carry enough medication to treat 2 attacks, I think it also becomes a part of the conversation, right?
So do you have those patients who say, "Well, it's my hand was swelling. I'm not going to need to go to work typing a keyboard today. Maybe I'll just." What do you say to them? "I'm not worth it." What do you say to them? Because
You know,
that's what they say.
yeah, they
Yeah.
they say it all the time. And what I say is one attack can lead into another attack. One attack can progress to a distant site that can become more life-threatening and can become more debilitating. And you really don't know. I mean, you really can't say that that mild left foot swell won't lead to something more severe within the course of that day.
Well, I liked what you said earlier with, when the anxiety is there and the unpredictability is there and they don't feel in control, what we want to do is try and shift that mindset to being empowered and more in control and making it more predictable. The best thing they can do in that case is to treat.
Is to treat. And then I find that when they delay those mild attacks, it's even more difficult for that on-demand rescue medication to be effective. I actually do mention that too, because I tell them if you delay, it could be more difficult to manage down the line.
And actually, there's some old data that's about 10 years old now, of when you have a peripheral attack, the disability. It's not got that fear. It's not going to kill you, and it's not going to be unbelievably painful. But that disability you have keeps you off work for longer than the abdominal attack. And I've had more than one person lose their jobs because they can't get their work boot on. And you know, why didn't you treat earlier?
Right. And that's a
Yeah.
part of the burden of
Yes.
disease, right? So taking treatment as early as possible, arresting that attack as soon as possible. The current available on-demand therapy for hereditary angioedema, I'm sure those of you are familiar with this. First line options, not all options, but first line options would include C1 esterase inhibitor replacement. This is delivered intravenously, either through plasma derived C1 inhibitor or human recombinant C1 inhibitor. Also, first line option would include icatibant, which is a bradykinin B2 receptor antagonist. This is delivered subcutaneously, and also ecallantide is a plasma kallikrein inhibitor that's also delivered subcutaneously. So this is what we currently have. So what we're currently using and currently giving to patients.
And that's interesting. It's 3 different sites of action, isn't it?
Right,
2 different moves.
right.
Yeah.
And so I do, have this discussion because I think, talking about the contact activation pathway and the different areas where we can target, may be key for some people. So, you know, when do we kind of think about long-term prophylaxis? Well, the guidelines recommend, and this is specifically the WAO-IACI, International Canadian Hereditary Angioedema, and the HAEA guidelines. So just generally speaking, their consensus is recommending long-term prophylaxis uh, in terms of a shared decision-making process as to whether that should be initiated for that individual patient. I think these 3 consortiums really have kind of come together to say this is just the general thought process. Shared decision-making, individualize it, mention it at every interaction when you have an interaction with that patient. Would you say that's
I
helpful?
I agree absolutely,
Yeah.
but I think we have to remember that it's about educating the patient
Sure.
because we as doctors are hugely influential, whatever we're talking about. So if we're just telling them what to do, you know, they're either going to do it or be non-compliant with therapy. So I think when the patient understands what the situation is and actually understands they can have a better way forward, then they'll they'll be interested in long-term prophylaxis if they have those, frequent or disabling attacks.
And my shared decision-making conversation evolves over time with my patients. I don't know if you find that it's not always the same every time I speak to them. It evolves. It depends on their current context of their own current situation.
You always want to meet the patient where they are,
Sure. Yeah.
and the patient will have a different background, a different understanding. If they're completely naive to the diagnosis and the treatment versus they're a family member of somebody who's had HAE and they've had treatment in the past. And so we always want to gain that understanding of where that patient is and then figure out where they want to go.
Right.
And then we act as their guide to take them where they want to go to better normalize their life. And I always ask the question, what's limiting you right now?
Yeah.
What is limiting you and how can we overcome that?
Yeah. So here are some first line options for long-term prophylaxis for hereditary angioedema. As again, those of you may be familiar with this, plasma-derived C1 inhibitor can be delivered intravenously or subcutaneously. Plasma kallikrein inhibitors, lanadelumab is administered subcutaneously every 2 weeks typically. That can lengthen out to every 4 weeks. Berotralstat is an oral prophylactic option that is administered daily. And for those plasma-derived C1 inhibitor options, those are typically administered every 3 to 4 days. So there's many different ways to administer long-term prophylaxis for hereditary angioedema, again, with different targets. Okay.
Do you ever start IV or is it very much subcutaneous?
I think it depends on the patient, their insurance, their lifestyle, and their ability to actually access, intravenously. Like, I do ask the question and, look at the vein integrity when it comes to delivering things intravenously and that frequency. So it is contingent on a few things, I think.
But I think one of the really great things, especially for those of us that have been in the space maybe 10, 15 years, is we now have a menu. We
Right.
have choice and we have options to where we can actually choose and pick and understand again where that patient is and make that shared decision making because not everyone's the same.
Yes. So there are some new and emerging agents also in terms of the prophylactic space. There's deucrictibant, which is extended release oral medication for prophylaxis. It is a bradykinin B2 receptor antagonist. It is not yet approved, but it is still under clinical investigation. There's also donidalorsen, and this is a kallikrein. Well, technically it's an antisense oligonucleotide that targets the mRNA of prekallikrein, therefore disrupting the production of active kallikrein. Again, this is a subcutaneous option, and this would be something that potentially could offer a more I should say, longer duration interval between injections. It's not yet approved; it's still under clinical investigation. Garadacimab is a monoclonal antibody that targets factor 12A, inhibiting it, and it is subcutaneously administered, again, providing some longer duration intervals for patients in terms of how often they're administering their medication. Approved in EU, Australia, UK, Japan, Switzerland, not yet approved in the United States. And then we have NTLA 2002, which is CRISPR-based gene editing type of therapy. It is administered IV uniquely. It is offering a very unique way of one infusion, if you will, for patients. Again, all of these pipeline, if you will, new and emerging agents that are in clinical development are offering different targets, different options, different lengths of frequency dosing intervals. And so we really are now looking at a really full menu. We've got pages of this menu now in terms of long-term prophylaxis.
And I will say that when my patients go on really any one of these new agents, they not only have much better control of their attacks, but they feel better. Do your patients, they have more energy? They didn't
Absolutely.
know that they were a little bit fatigued and a little bit leaky before,
I think
maybe?
sometimes a lot of these patients may acclimate to feeling a certain way,
Yes.
and that becomes their normal, and then they
It
don't
has
really
been their
realize
norm. They're
what
born with a
what
genetic
it's doing.
variant.
Right.
Yeah.
So this is great. So let's now shift.
It is time to rove to get some audience impact. My favorite part, time to mingle with the audience. It's always nice as a medical journalist to get your perspective immediately after hearing some new information. So, question one is, what are common myths you debunk with your patients when it comes to HAE attacks? What are common myths you debunk with your patients when it comes to HAE attacks? Who would like to contribute? Would love to hear what's on people's minds. Today is all about being didactic, but it's also about being interactive to establish a dialogue. Did I see a hand over here? Would you like to contribute? Oh, great. Can you stand up for us? Or I can come down to you. So, what do you think? I can repeat the question. What are common myths you debunk with your patients when it comes to HAE attacks? There have to be some myths that get brought up in conversation.
I'm Mary Murphy. I'm a nurse from Barts Health in the UK. Now that there's lots of new treatments available, I think some of the patients are still in the mindset of the past that they want to preserve their medication. They don't want to use the medication unless it's a very severe attack. But now that we've got funding, it's maybe different, obviously, in the States, but it's just encouraging them to treat attacks and to not reserve their medication, not to be afraid to use their medication.
Change is hard. Change is hard. So we have to try to debunk the myths. Anyone else? I'll go to our next question. What challenges do you see with patients acutely treating HAE attacks? What are your thoughts?
I think one of the largest challenges are when these patients present to the emergency departments. They have to provide a lot of education to our colleagues regarding what medications will benefit them. And so they could be treated with steroids, antihistamines, epinephrine. I'm sure we've all seen that. And so we're really asking patients a lot, like to educate providers when it comes to them being in critical illness.
Very important point. The emergency providers, right? It's like starting from square one, sort of. What do you think, doctors? What do you think of that feedback? Terrific insight.
No, I think that's great because not only treatment options, but stay with her. Do you find it that patients often have to educate the emergency room even on just the disease?
Yeah,
Convincing them.
I do. And I'm an allergy fellow, so I am only 2 years into this, but I will say we get consulted in the hospital for patients that have HAE, and you look at their MAR and they've been treated with medications that weren't effective. And so it really does provide a lot of education.
And what do
Important
you
point.
do? What do you do to prepare your patient for that pretty much certainty that they'll be in a strange place, a strange emergency room? They'll be having an attack, partly because they're on holiday, the stress. They'll be having that attack. How do you help them prepare for that time?
I mean, I think a lot of it is education. We can speak as much as we want, but I think writing things down for patients, like we have a lot of action plans when it comes for, I don't know, FPIES versus IgE-mediated food allergy. And so it could be as easy as that, I think, to give patients something that they can physically provide with them for a provider to read so they don't have to remember all of this information when they're stressed.
Perhaps a journal that they have with them. Dr. Jones, were you going to say something?
Yeah, I actually had this come up with a patient 2 weeks ago where they were new to me, but they had gone to the emergency room and they weren't believed and they weren't given anything. So we give them an emergency, have a form where it's like an emergency form. And on the top, it describes what they have. You have hereditary angioedema. These medications don't work, so don't give them antihistamines, don't give them steroids or epinephrine. And here's the medications that do work, and this is what is prescribed. And so it's very clear, and so they can hand that to the doctor uh, right in hand, and that I found that to be very helpful.
And of course, they have to have their own high cost medication with them because in many hospitals, they're not going to have it in stock. And if they do, they're going to be scrabbling around, waiting that hour, looking for it or calling the blood bank or whatever. Yeah.
Well, thank you so much. A really insightful and important scenario to discuss and learn from. Thank you again for your participation. I'm going to toss it back to Dr. Longhurst as I head back to the stage.
Okay.
You're up to bat. Thank you.
So I'm going to talk about the some more of the barriers, and I don't think. Oh yes. So you heard from June, the blonde lady, the difficulties she was having, and I know June. She used to be my patient. I can tell you that she's not telling you a lot of how it is. Patients to me, they come to me, they say, "I'm really fine," and that's code for I've been like this all my life. I've sort of learnt to live with it. June didn't even mention her peripheral attacks. until I'd known her about 6 months, and she'd got over the ITU admissions, the terrible abdominal attacks. Um, this is actually data from a survey done in the United States. I wasn't, I thought this was going to be very boring, but once I started looking at the data, I was really blown over because, firstly, how many people have as many as 4 out of 5 HA attacks being treated by their patients? We recommend that they're all treated. How many people have all patients treat all attacks? No one. How many people have patients that treat most patients treating most attacks? Have we progressed?
One over here.
No, we have not.
One.
One there. What about you two?
I would say it's not the majority of attacks.
No.
And there's many reasons for that.
Yes, we'll come to that.
Yes.
So more than 50% don't treat all the attacks. And then 2/3 almost don't carry their HA and demanded treatment. And this is not just popping out to the shops. This is going to work for the day. So like June said, she's got to call someone to bring her back home from work so that she can give her medication. Or people go for up to 4.5 hours without their medication.
So is
driving away
Is
from
June consciously leaving her on-demand medication at home?
for some reason, June did not see that it was appropriate to bring her medication into
To
work, to
okay.
her work. And this is quite a common scenario. I did try and help her resolve that
Yes.
because clearly you need your medication at work.
Right.
Otherwise, your employer and you will suffer and you will lose your job. And we know that people should treat attacks immediately on recognition because that attack will then be controlled much more quickly, be less severe, and the duration of the attack will be less. But only 40% of people do it in America, and these are educated people in the HAEA, so they're the advocates already. And despite realizing that they might be starting an attack, the vast majority delay treatment. And the scenario goes usually, it's the evening, I've just gone to bed, I've got a little bit of grumbling something in my abdomen, but maybe it's something I ate. And I don't know how many people have had patients say that to them. And they wake up later in the night, they're in agony, they're vomiting. Their treatment doesn't work quite as well as maybe it would have done, and they've got to take the next day off work because they're feeling exhausted and the pain and the swelling still hasn't gone away enough for them to return to work. So this is the situation we're waiting for. And patients do wait. They want to know that it's a proper attack.
But that 2.4 hours, if you notice, that's on average
On
2.4. For some people, it's even longer than that. Within that time frame, wouldn't you say that things can really progress within that time frame? So it's interesting that that's just the average time that it's taking people to actually take a rescue medication.
And when you look at that very old C1 inhibitor data, when you look at the course of the attack, there's low-level symptoms for a few hours, but suddenly you get that exponential worsening.
Right.
And if it's an abdominal attack, you're then going to be in a lot of pain for a long time and disabled, and your significant other will be staying at home to look after the kids or whatever. If it's a laryngeal attack, it's happened several times to my patients that you suddenly go from a little bit of something in the throat to breathing through a pinhole, and not to my patients, but actually that's how people die when they know they've got C1 inhibitor. So there's a lot of education. So the single most common reason, not sure if the attack's severe enough to treat, but we know that all attacks should be treated immediately. We know that the drugs are very expensive, but maybe we're giving slightly mixed messages to our patients. And the simple thing is you treat that attack, immediately recognize it. And when you do that, if you don't do that, you are paying the price personally, as is your family, as is your employer. So you're not promoting a healthy society, and we can't really afford not to do that. Um,
But these are so many other reasons, not having, like June, not
yeah,
having
yeah.
her on-demand
She's
rescue.
gone to work. It's half an hour
Yeah,
from where she lives. She's
right.
got an important meeting. She doesn't have the treatment. She's got to go home, and she had pretty high-powered
I
job.
I think my patients do mention the injection pain, stinging, burning
Yeah.
is a major issue for them. I mean, the treatment, the burden of having HAE is one thing, and then there's also the burden of treating it as well. So this would,
Yeah.
I would say, be what the majority of my patients do mention to me when I'm with them. And then if you're at work, not having that private area to
Mm.
just to
Yeah.
to feel comfortable administering the medication that you're taking.
And do you find that the injection pain, it's that barrier that your patient has to get over the first time they ever treat at home on their own? They've got usually what happens is they don't treat, they suffer the consequences, and then one day they have an abdominal attack that's progressing very fast, and they do treat, and actually it's a revelation, and they've crossed over, and after that it's not quite so difficult. But I think it's a real problem early on in their HAE experience.
Yeah, I agree.
Yeah. And then something that we doctors can do, we don't want to waste money, we don't want to waste drugs, but the price of patients who have to go to the pharmacy has to order it in, they've run out, there's huge anxiety, they have an extra attack, they're in the emergency room. Um, we need to make sure that we have a plan that they can always have those extra um, medications. And if they're having attacks, 4 or 5 times a month, then they need more. I think it's not enough to have to go to the pharmacy every week and get refills. So I do like this diagram because again it comes out of this USHA survey, um, and it just explains it's people explaining to people like you and me what happens when they feel an attack coming on. So if you look at the left, firstly there's the trigger. Mostly people don't know what the trigger is. It's a micro trigger to some area of their body, but it may be that they'll get prodromal symptoms, but some hours later they'll get very low level symptoms. And actually, these are the ones people like to ignore. And the low level symptoms will usually progress, and their anxiety and the sort of emotional burden they're suffering will increase very slowly. But when the attack starts to progress, obviously much more anxiety, and it's relieved when they make the decision to treat. And then, of course, has the treatment worked? And if you've left it too late, the treatment will not work quite so well. And so there's a second sort of peak of anxiety, which once you've given the treatment, you know that it's going to work. You can feel it kicking in, the anxiety subsides. And I just thought that explained very clearly what I think our patients go for. So I'm actually going to hand you over to Pam now, who's a lady living in the United States, and she's actually going to tell us how the process of deciding on treatment and treating feels for her.
Some of the most challenging aspects of living with HAE are number one, just making sure that you're prepared that if an attack happens, okay, how am I going to handle this? Do I have the on demand medication available? And is there a place where I can go administer that treatment no matter what kind of treatment that you've got? You can't just whip out a shot and stick it in your stomach in front of a lot of people. So you've got to have a place that's convenient and somewhat private so that you can handle that. And then it's to make sure that you can do that in a timely manner so that you can stop the attack where it is. Your body can resolve it with the least amount of effect on you, and you can go forward. So it's thinking through that in advance, especially when you're not having attacks, and just being prepared and not getting caught in a situation of, oh my gosh, my medicine's in the car or I left it at home and now what am I going to do? So it's being prepared for the unexpected because HAE is always challenging in that because you never know when it's going to show up.
All right. Thank you so much, Pam, for your bravery and sharing your lived experience because it is so important. I'm going to hand the mic over to Dr. Burnett.
Yay. So, breaking news. We're going to now talk about innovation in on demand treatment for HAE. The first thing up is here we have Subaltrolstat. It's under clinical investigation. It is a plasma kallikrein inhibitor that is an oral medication. And you can see here the contact activation pathway and the specific place where sebetralstat is targeting this particular pathway. Here it is shown to be at the level of uh, inhibiting plasma kallikrein uh, and preventing that downstream effect, if you will, of cleaving high molecular weight kininogen, releasing bradykinin, where bradykinin can then latch on to its receptor and trigger vascular permeability and vasodilation and the swelling of hereditary angioedema. The CONFIDENT trial was the phase 3 clinical trial that studied sebetralstat, which again is an oral plasma kallikrein inhibitor. This was a phase 3 double-blind, three-way crossover trial. Uh, Patients in the clinical trial, there were 136 participants, at least 12 years of age and older, with either type 1 or type 2 hereditary angioedema. They were in the clinical trial. Again, this is an on-demand medication, so they had to have at least 3 attacks that were treated 3 different ways. There were 6 different sequences, sequence A all the way through sequence F, which allowed for these 136 participants to experience 3 separate attacks. Each attack was either treated with 300 milligrams of sebetralstat, 600 milligrams of sebetralstat, or a placebo. Again, this was an on-demand rescue medication study, and they could actually do up to 2 doses per attack if they needed to. Here we have the primary endpoint of the CONFIDENT trial, which was the time to beginning of symptom relief, which was defined by the patient global impression of change, which is a 7-point scale. We call it the PGIC. And so that rating ranges from essentially much worse to much better. And these patients had to have at least 2 or greater consecutive time points within a 12-hour period of time after they were first administered the trial agent. And so again, that primary endpoint is that PGIC is defining those patients had to have felt a little better to meet that primary endpoint on at least 2 or greater consecutive time points. And so what we're looking at here in terms of this data is that for the sebetralstat 300 milligram dosing and the sebetralstat 600 milligram dosing, we can see that the median time to the beginning of symptom onset relief was 1.61 for sebetralstat 300 and 1.79 hours for sebetralstat 600 milligrams. And that's compared to 6.72 hours median time for placebo. So again, both the sebetralstat 300 milligrams and 600 milligrams had a greater degree of improvement in terms of the time that it took to get to the beginning of that symptom relief, as defined by feeling a little bit better on greater than or equal to 2 consecutive time points. What they also took a look at in the CONFIDENT trial was complete resolution of an HAE attack as defined by the Patient Global Impression of Severity, the PGIS scale, which is a 5-point scale, very severe, severe, moderate, mild, or none. The endpoint defined as a rating of none on the PGIS scale within 24 hours after first administration of that agent. And so what we're essentially looking at is between the 300 milligram, the 600 milligram dosing of sebetralstat versus placebo, looking at the percent of attacks that achieved complete resolution. And you can see for the 600 was 49.5%, for sebetralstat 300 is 42.5%, for placebo it was 27.4% in terms of the percent attacks that were completely resolved. Safety from the CONFIDENT trial, you can see any adverse event for sebetralstat 300, 600, and placebo were fairly similar here. In terms of gastrointestinal treatment emergent adverse events within 3 days after administration. Dyspepsia was reported in the subetrostat 300 milligram. Nausea was reported in the subetrostat 600 and placebo in one patient for all of those. In terms of fatigue, it was one patient in the subetrostat 300. Headache was reported in one patient in the 600 milligram and one in the placebo. Altered taste, one in the placebo. Menstruation irregularity was one person in the placebo group and also one person in the placebo group for rash. So here we have those safety findings. I'm going to now turn it over to you, Hillary, to talk about the
Yeah.
curriculum.
So we have an abundance of riches, not one tablet for acute treatment, but two, and they're working at different locations. So I'm going to talk about deucrictibant, which is a bradykinin B2 receptor antagonist, so working at the same on the same target as icatibant does. But this, as well, sebetralstat and deucrictibant both have quite long half-lives. I can't say whether that translates into better longevity, but it's it's what I would like to see. And deucrictibant doesn't have quite so much data as sebetralstat, but what it does have is equally promising. So the RAPIDe-1 phase 2 trial was really a safety trial, but it did involve quite a few patients. And it looked at 3 doses, and there was rapid onset of action, symptom relief, a very high rate of response. So I think that 1.1 hours was the median time to onset of relief, which is hugely important. It's that good, the treatment's working bit where the anxiety starts to drop. And I think the vast majority of patients were had resolved or almost resolved within 24 hours. And again, this is part 2, so there's a double-blind phase, 3 trials, and there's an open label phase. So there were only 19 patients in this trial, but again, this is telling me HAE patients have a lot more attacks than they're telling us. There were 337 attacks, and I might ask, why are these patients not on effective prophylaxis? And obviously, that's another challenge for us, but it was very well tolerated. There were very few treatment-related effects. They were quite similar to what we saw in the placebo, and then no serious adverse events. So I think all these new drugs have a very high level of tolerability and safety. Obviously, we need longer-term studies, but looking very promising indeed. So here we are, 1.1 hours to onset of symptom relief, 2.7 to substantial symptom relief, and this is using the same patient-reported outcome instrument. It's the first of 2 time points that the patient starts to feel a little better, so can feel that the drug is working. And complete attack resolution, median of 11 hours.
Thank you so much, Doctor. Right now, I'd like to throw to another quick video and introduce our remote correspondent, Dr. Timothy Craig. He's a professor of medicine at Penn State, and he's a leader in the field of allergy and immunology. And he's going to talk about what it's like talking to patients about their on-demand treatment.
I'm Timothy Craig. Pleasure to be here. So, one of the things that I always worry about is the strategy in order to ensure that people are using their rescue medication. And one of the things I do is kind of tell them how important it is. The earlier they do it, the quicker they do it, the less likely they are to have symptoms that persist hours to maybe even days. And in fact, to delay their therapy too long, they may not even really have any benefit from it. The strategies to get people to use their medication as early as possible maybe includes a few discussions. One is maybe you overtreat a little too much or occasionally, so if you get belly pain, could be a virus. It could be that you didn't take your lactase with your milk, or you might have an attack. But that's okay to try to treat that so it doesn't progress. Even though it may be a virus and your symptoms may persist despite therapy, you'll find that out. I don't always condone people treating at the time of their prodrome, but there are some people who know when they're going to have an attack from having symptoms that are very early on. And for some people, that may be a good time to treat. That is, if they have a little nausea, don't wait until you vomit, or don't wait until your belly pain is really intense, or if you're having paresthesias on your arm and you know that an attack's going to follow that, then go ahead and treat at that time. For the majority of people, though, I don't think they really understand prodromes. And then I say, as soon as your symptoms start, then that's when you inject yourself. One of the nice things I think, though, is if we do have an oral medication, that is going to change the playing field a lot, because then, you're not going to be carrying syringes, or, the need for medications that are IV. You're going to have it in your pocket. You just open it up wherever you are and pop a pill. It just will make it very easy to take the medication. And I think that's going to be very exciting in the future.
Absolutely. Thank you so much, Dr. Craig, for your insight. All right, time is almost up. An hour goes by very fast. We're going to have some concluding remarks, starting with Dr. Jones. We'll go down the panel, and then we'll have some time for some quick Q&A.
I think one of the take homes for me is partnering with our patients to understand where they're at and meeting them where they're at, so that we can discuss what their challenges are. What are the barriers that prevent them from making that decision to treat every attack as early as possible? So we want to discuss the new therapies that are coming out. It's the importance of individualizing HAE management, because not every person is in the same situation, and the things that are important to them may vary. But I think we need to enhance that communication between clinicians and patients. And there's a lot of tools out there to help us, understand what the patient needs, and also understand what those challenges are, and then how can we best guide them to where they want to go.
And I think from my standpoint, I always look at hereditary angioedema for my patients as an ever evolving discussion. It's not stationary. I think every time that I talk to them and see them back for follow up, I think it's an opportunity to talk about burden of disease, talk again about burden of whatever their treatment option is at the time, mention the clinical trials that are taking place currently, because if something's not working with the current landscape, maybe we can look into the future a little bit for patients who may need a future option if should it become available. And so I try to do a preview for them, to really, encourage them. Don't give up. We're gonna hang in there and continue to evolve within the journey of their HAE journey. And shared decision making is not easy. It is actually quite challenging in some instances, but it is an opportunity to kind of move the needle with patients and get them contextually and an optimal quality of life for whatever they are dealing with. So
Yeah, and I think our patient associations are asking to be healthy.
yeah.
It's not unreasonable. Unfortunately, they have a rare disease, but if we want our patients to be healthy, we have to tell them they and their families and their employers they're worth it, and they can treat as soon as they notice that first symptom and really nip that attack in the bud.
So don't wait.
Don't wait. Don't
Yeah.
wait. Treat
Yeah.
on recognition. If you're having too many attacks or it's too disruptive, there is prophylaxis that can actually, yes, that can help you as well.
Well, we are out of time. We could go on and on and on, but thank you so very much to our incredible panel and your insight. It's been terrific. Thank you so much for our attendees and my roving reportees. We had a great scenario. Thank you so much for your insight. Thank you for being here, and enjoy Glasgow.